Apologies for the very extended title. It was actually one of those topics that Mr. Precious kept sending me emails to say, listen, I need this list, and I kept trying to defer it until I ran out of time. And at 2 o'clock one morning, I decided, let's give him something that looked interesting. 3 weeks ago, I looked at it and thought, what the hell was I doing? So, apologies for that, but I tried to work around it. I think it's on a couple of cable. Okay, yeah, that's the topic I'm...
With Anton and the surgical knife.
Is that any better? Okay, just bring it off. Can everyone hear me?
Yes.
Okay, perfect. Okay, just a very quick background, some information. I'm going to try and keep it as simple as I can. I've prepared as many slides, so I speak less and read more, try and integrate those two. And I know it's just before lunch, I'm pre-graveyard shift, so I've got the opportunity to have some of your attention. So let's get started. Essentially, my main focus is medical legal consulting. I consult for the likes of the Road Accident Fund, various other organizations and companies in industry. I don't want you to go through all of that detail. The key point is we work for the likes of the Road Accident Fund. We provide independent medical examinations, drug utilization review, treatment interventions, future medical costs, assists with quantum, etc. I do have a background in, as my colleague spoke earlier, I've also studied the postgrad certificate in medicine and law. I've also done intellectual property law and a few other things. So I have a little bit of background on what actually goes on and what's required. I've appeared in court both personally and as expert testimony. So I know what the processes are, and I think it lends an insight, as mentioned earlier. There's very limited skills in the industry in that sphere. In terms of academic background, it's just a skim to say I actually do know what I'm talking about, hopefully. And I'm not even going to hold that very long. The intent was just to say I have some credentials. I think the major disclaimer is I do work for the Department of Defense, and my opinion stated here as they've demanded is strictly my personal opinions. I don't speak for the organization and their work, more especially in light of the review of them sending intelligence to review those associated with CAR, some of those patients. Also, to our learned colleagues and our friends here today, if I may take the liberty of saying so, there's no intention of discounting the value or the capabilities of our non-physician colleagues and professionals and managers. This is purely to lend an insight and perspective from one perspective of one individual into what my thoughts are on this. In terms of the concerns mentioned, as Prof mentioned earlier, it is actually seem to have flown, or the topics have flowed into each other, which seem to have helped it to build on into the discussions. There was discussions around the rationing of care and resources, as mentioned by Prof. Johnson yesterday, the incentivization model of usage of medicines and dispensing, the cost-effective medicine management, benefits management, protocol-based care, and the concerns came around deviation from protocols, who to go to, what to go to, what to do in those instances, and the discussions around total care continuum versus short-term care savings, and chronic versus acute management. Some of the topics that were mentioned, and I will elaborate further on those, is seeing the patient in a totality and as a holistic system, as a holistic individual, not just as a claim number for cost X. And that perspective is what I'm going to lend to this. I think some of the needs that I've found that came through on the discussion were needs of patients as well as cost management, and trying to find a balance and mitigate between those two. The concerns around fraud and wastage, the reviews as today on legislation and compliance with detections of these newer processes of the entrapments, etc. The ongoing monitoring and evaluation and where these actually take place. Cost reduction strategies, service delivery and drug utilization review, and review of current managed healthcare systems. I think we just can skip that. Sorry, that slide should have come out. As again, the intent of the presentation is not to discount current appointments, purely to stimulate perspectives and options, and not providing solutions, but exploring real opportunities. I think the managed healthcare system, if one were to look at the structure to a large extent, is, and this is where our discussions centered around yesterday, what are doctors doing for patients, and what roles the managed healthcare systems, whatever the organizations be, in what they do with primary care, because all of this is a point of access to the patient, and that's what the bone of contention is. There's going to be investigations, there's going to be entrapments, there's going to be queries on everything that happens here with the skills of the doctors. But as I broached the topic yesterday, what happens on that level, on executive leadership? Who's making those decisions? Who's guiding the managed healthcare profession and the decisions they make? Because is there enough insight? Is there enough foresight on the decisions made? On where these two start to talk to each other? Because at the end of the day, if the executive leadership of the managed healthcare system don't take into consideration the basics of what we hear for primary health care, they lose sight of the patient. It's not just about cost saving. Yes, it's a business. Yes, it has to work on profitability and minimizing costs, but it has to look at the long-term cost saving. In marketing, they call it customer lifetime value. I'm just going to refer to it as lifetime value of these specific patients. There obviously are the challenges within the system of waiting to see doctors and getting their consult with some of their specialized skills. But that's just to keep us going easy for a bit. As an example, just to break away for a moment, because I want us to step away from managed health care and the structured system and look at it from an industry point of view. Just for the moment, and ask ourselves, when you get into vehicle manufacturing, and this is a layman's perspective on by no measure any expert or have any expertise in this field, but one usually looks at compatibility of components. When they're building these systems, it's compatibility of components. Strengths of materials, and I know these few fancy terms because my brother's an engineer, but strengths of materials, that means the durability of what they're using. Will it last? Will it stay that entire warranty period? Will it give you value and give you the safety measures that you need in these built vehicles? Also then one extends into features. What are the fancy components that are required for the features? And the performance. That is typically what a lot of people now look for. But looking at fuel price, they're actually looking for cost savings and reductions of cost. The cost model is something that is structured on the outside, but the discussion around looking at vehicle manufacturing, those decisions are not made by the accountants. They're not made by the actuaries. They're made by people who have skills and expertise within the environment, within the engineering fraternity, within the vehicle manufacturing fraternity. Servicing and maintenance, this is something that we see by a lot of the brands, and as Mercedes usually has a big argument, and the other brands, general parts and label versus cheaper imports. People are looking for cheaper alternatives. But will you put your life at risk by not using genuine parts and using cheaper as they call grade imports? The question there comes in about quality and durability. Will this product last? Will using filter X or part X give me the same value on my premium, whatever, German vehicle, German vehicle? The decision on what to use in terms of general parts and labor is usually decided by the engineers after extensive testing. That means they have experience in using these things. It's not their first Toyota or their first Mercedes in which they said, let's save 500 Rand on this part. They made those decisions and recommendations, one, from a profitability point of view, but also from a longevity point of view, in which you're actually getting genuine value for money. Now, let's look at this scenario. Your Mercedes-Benz broke down, you're driving Northern Mpumalanga near now. It's towed to a dealership. They plug it onto the fancy Stockholm system that Mercedes-Benz talks to your car. And then they decide, okay, we don't know what's going on. We find an error code, and the dealer technician calls Mercedes-Benz. So they call Mercedes-Benz South Africa. Who would you want to be giving advice? Would you want the accountant or the actuary to be advising? Would he be deciding, this is actually going to make profit for us? Or would you want someone who actually has skills in this kind of environment? Somebody who knows the vehicle, who knows what needs to be done. My personal preference would be, I want to work with somebody who's been there, who's worked their way up, and knows exactly what goes on in managing those vehicles and maintaining those. In terms of definition of healthcare, just as a quick recap of what our colleagues mentioned yesterday, healthcare, according to Wikipedia, is the diagnosis, treatment, and prevention of disease, illness, injury, and physical and mental impairments in humans. And healthcare is delivered by those practitioners. In medicine, we're using the various modalities, but the main focus is humans. Nowhere in healthcare does one look at purely cost model. In terms of managed healthcare, yes, there is a term of intended reduction of costs by providing healthcare benefits and improving the quality of care. The key focus is on quality of care. But you've got to ask yourselves, who has the capacity to understand and the insight of what level of quality of care actually makes financial sense? Because you could save on that catheter today or that central line today, but replace it in 3 days. Or put an expensive one, which is probably twice the price, that's going to last you 3 weeks. Or Joseph antibiotics, replacing with far cheaper generics, or the originals, or a specific antibiotic or drugs are specifically excluded, yet the long-term management. Would you rather authorize treatment for patient X for his condition, or, as usually happens with some of our medicals, deny the treatment now of 500 Rand for that treatment for a week, the patient gets admitted for 2 weeks and then ends up in high care. Total bill, 85, 90,000 Rand. We need to start weighing up the practical cost in long-term view. I'm not going to get into too much details of managed healthcare organizations. My perspective is simply one thing. Doctors and medical professionals are in the business of saving lives. They're there to optimize quality of life. If they cannot reduce suffering, they at least optimize health. And that is their primary function. They've had time, they've had experience to go through all of that. And there are obviously those doctors who, as mentioned yesterday, are innovative and entrepreneurial. There's no guarantee of what they're going to offer, but they'll offer you something. My view, again, as mentioned yesterday, is a lot of focus has been put on the primary caregiver. What is he doing for the patient? How much is he claiming? Why is he claiming? Because that medical fund is administered by those administrators. My thinking is, what can we optimize here? Because everybody's arguing the primary caregiver is not doing what we're telling him to do. My questioning is, who's deciding what should and shouldn't be done? Who's giving the guidelines? Who's preparing those protocols? Who's answering that call when you phone for the authorization for that CT scan or that specific antibiotic that's being turned down? We'll get into exactly in a few cases of what actually happens today and who actually manages those kind of environments. Just a broad overview of a few things that I will be traversing very, very briefly. In terms of benefits of having doctors or medical professionals, they have a specific expertise, they have the experience, they have actually done the drug utilization. That means they've dealt with patients on the cold face as it is. They have worked with special investigations. They have studied scientific data. They've had to be able to assimilate and process such information. They have insight and understanding and the capacity to make quick decisions. And they, to a large extent, I'm not saying all practitioners, but to some extent they've worked with optimal treatment review. Even if they don't do it currently, they've had exposure to doing that. In terms of expertise, there's been extensive training in healthcare and patient management. Now, one can't dispute that because 6 years in medical school is a forced system. Yes, if you come back with a Chinese degree or a Mauritian degree with 3 years, one's going to start to question that. But if you've got the extensive training locally, you've got the insight, you've done the training, and you've done physical patient management, you've got far better insight than someone who's never dealt with a patient. They've dealt with a claim number. And there's a huge distinction. Because the only time the person who's only dealt with a claim number can internalize that is if that claim number relates to his family, her family, or himself. Because then suddenly it's not a claim number. It's an individual and the person actually involved. Integrated management of patients. And they've dealt with this. I've worked with the likes of California, I've worked in a few different hospitals around the country. Integrated management is managing various patients. Because a lot of times you get feedback, they say, but doctor, you don't understand, we need to manage X amount of people with this pool of funding. If you've worked in states which you have to have done during your earlier years, you will understand what it takes to integrate, to manage, because you're not claiming from anything. You're claiming from that trolley that's already halfway empty in that casualty, be it in California or Jubilee Hospital or the Performance Club. That's local management on a very, very primary level. As Anton will bear out, the more rural settings, you're doing management directly. You're the managed healthcare system in totality. You decide what works for that patient, what doesn't, and what you can handle to the next one. Resource, as I mentioned, they're resource-limited environments and have worked in various disciplines. And now this is key because a lot of people, or a lot of the case managers, I would say managers, the points of contact, correct? Then discuss with the doctor, how can you comment on this area of expertise? You're not a gynecologist, how can you want to do pap smear? Or you're not an ophthalmologist, how can you do the eye exam? Or you're not a radiologist or not an orthopedic surgeon, why do you want a CT scan? Yet knowing just a consultation with the orthopedic surgeon is going to cost you $1,200, and then he's going to send the patient off and he's going to come back for a review. But generalists to a large extent, which are the primary caregivers, have worked in every department. They've had to work in every department. That is why they're general practitioners. They've seen patients on all levels. They've had to manage them effectively and prove their capacity to do so before they even graduated. And this is critical because making decisions or making requests in specific departments does not require, as discussed yesterday, you do not need to go to a gynecologist for a pap smear, a GP can. You go to a state hospital, you're probably going to get a student who's an intern to it, and they're probably very capable of doing that very effectively. In terms of experience, as mentioned again, they've been exposed to patients both in a primary and specialized environment. And that a lot of people seem to discount. When one is training in the medical programs, be it during their primary degree, during their internship, community service, or whatever stage of their training, they have worked in specialized environments. They have to spend time, 3 months, 6 months, whatever they chose, in those specific domains. That means they do have insight. They may not have a master's in the domain, but that does not discount that they have experience in that. Professional skills are reviewed at least twice to prove they are competent in what they do. They have to pass their degree to at least graduate, and then pass the internship to say, I can do this, I can implement this, I can prove to you I am capable of functioning within that specific area of medicine. In terms of drug utilization, these colleagues of ours and the doctors have used variations of drugs. They've seen the benefits and pitfalls. They have actually seen what the difference between a different cephalosporin is or a fluoroquinolone or a different class of antibiotic is because they've dealt with it. They can make the distinguishing difference between this patient isn't responding to this and not responding to that, outside of the protocols that are decided by the arbitrary committee. The decision to deal with that patient can be justified by someone who's actually been there to know exactly what's going on. There has been experience in optimizing treatment in terms of the compounded disease load that we have in South Africa. We have had probably some of the largest disease profiles across the world. We have some of the most limited resources, but you see everything. We have colleagues of ours who come here from the States, associate professors, full professors. They spend time here purely to get that experience because they come from esteemed institutions, but they're talking in theory, they're talking on pictures, they're talking on cases. They're not seeing what you're seeing, and I'll use the example that I know. They're not seeing the patients that you're seeing at Color Farm. They're not seeing the patients at Jubilee. They're not seeing the patients at Steve Biko because they haven't had the opportunity to do so. Because in those kind of environments, specialized care or generalists have limited access to what specialists do. So the disease burden of the medical doctors here, they have seen it already. You're in healthcare, you've seen it all. There's no point of saying, but you have not seen this and you have no insight into what's going on. This again is what I'm going to rub home again. They work with living patients, not with claims. Not with this isn't justified or that's not justified. They work with human beings. They work with people like yourselves, because when you're sick, that doctor's probably going to be treating you. Whether you're a doctor or not, at some point, someone will be treating you. And they have insight into your health, not your claim, not your protocol. Special investigations, just to rush over this, they have worked with ranges of investigations. They do have opportunities to know what's cost effective and not. And I'm not disputing the fact that there's extreme abuse within the system. But having someone who's worked with it would have a better opportunity to decide, is this justified in the short term to mitigate cost in the long term? But having that experience adds purely that. In terms of clinical trials and studies, most of us have had to do our CPDs, if not at an academic level, but you need to be up to date with what's actually going on. You need to see the studies, you need the clinical data, you need to understand what's going on, what's been proven, and what's been peer reviewed, because you do get radical studies that get kicked out in the lines of HIV and other chronic diseases, but you also get data sets in which you say, this is relevant, it is going to work for us. Because yesterday we broached the topic of local relevance of studies. That's very, very important, because a lot of the protocols are designed and a lot of guidelines are designed on what was published in the New England Journal of Medicine or something else in the United States. It is good, but is it relevant? Do they have the same patient burden that we do? Do they have the same patient load and disease impact that we do? One has to now try and qualify and quantify those to actually make sense of that. In terms of insight and understanding, in terms of when a doctor sees a patient, and you know, it's a joke that some make crudely with their patients, they ask, but how is it, doctor, you bill so much for so little time? That doctor has to assimilate everything he's learned in all his experience within those 30 seconds, and then make a decision, these are my preferred options, these are my differential diagnoses, this is what I'm going to work on. They understand pathophysiology. They're not there to say, patient X doesn't qualify, this is excluded. He actually has insight in saying, I know what's causing this. Or to a large extent, I suspect this is causing this. They understand how drugs actually work within the body, the kinetics and the dynamics, and more importantly, drug interactions. Because I've had a lot of cases where you get a case manager saying, but we recommend this. Then you tell them, if you know the patient's on this treatment chronically, they tell you that's got nothing to do with it. But they don't realize those drugs work on probably similar receptors. They don't realize that You can give the patient what they recommend, and then the patient's going to be hospitalized a week later for drug overload or dysfunction of some enzyme within the body system. Then Medic-legal has to authorize an admission, maybe a high care, maybe specialists involved, and if you're lucky, they'll bring in an endocrinologist to tell you exactly what's going on, for something that could have been avoided if someone understood the pathophysiology and made decisions on understanding people, not just claim numbers. Capacity to make quick decisions. There are lots of times where you end up in a long, protracted discussion, fighting with managed healthcare agents, who then want to justify why it can't be paid. Yet, someone who actually knows what's important, what needs to be done, because by the time you actually get to the medical advisor, who's probably in conference or on leave or on another call, he'll get back to you 6 to 8 hours later. Your patient was in an accident, and there is actually, this is an example. Medical student in her 3rd year at the University of Pretoria was sent on a varsity assignment. They attended the students' conference, they were on the way back. Head-on collision, she had a fracture of her spine. Medic-legal refused to pay. The orthopedic surgeon said, I want an MRI now. They've got the golden 2 hours to decide, can we intervene now or not? Medic-legal refused. A protracted fight for 6 hours. Why? Because this happened just after midnight. No medical advisor was available. The authorization agent said, deal with this in office hours. Family had to get family from another town to bring in 15,000 rand hard cash. Then the hospital operated. That then medical student is now a quadriplegic. She could have been saved, as one example that I need to mention. But the decision, the turnaround time is too long. And I'll show you what actually happens to one organization that we know of personally, who actually makes those decisions. And the questionability of, I'm not saying they're incompetent, but the level of competence and experience. Obviously, in terms of the topics, I mentioned a lot of benefits, but value is something that's relative. But when it comes to healthcare, our value quantifies to two things: life and quality of life. We can't decide the period of life, but we can decide what is that relative worth. And you've got to ask yourselves, it's good to say that's worth saving 5,000 rand in that patient. If it was your sister or your mother, is that 5,000 rand now relative? But that's questions you've got to ask yourselves. I think this is exactly where we bring it down to. That's management. This is life. This is where you need people who have insight of what we're actually dealing with, because managed healthcare is supposed to assist with management of maintaining that. There are those who run short of resources, and thankfully, as mentioned earlier, there is Google and other websites. But not everyone's lost. A lot of people do actually know what they do. Does it make sense having an MBCHB with an MBA, MBL, MBP, whatever the qualification be, some management qualification? And one has to then quantify, does it make sense having a doctor with management or a manager with some medical exposure? Can you correlate those two? You'd get your traditional CEOs who I immensely respect, who have non-medical case reviews, which is the common cause. They have medical advisors and they have extensive business experience. But the business we're talking about is in bodies, and a system that we still cannot completely replicate, something that's beyond the capacity of man to fully comprehend. But we make it function as far optimally as we can. Doctor CEOs, if appointed, which many institutions do have their own personal experience, not someone's advice. They have medical expertise because they've done the time. They've passed the exams, they've worked in those hospitals, they've been underpaid, overworked, currently not getting overtime. They also have management skills if they do the relevant programs. And the management development program, as far as I'm told, varies between 6 months to a year. Obviously, you'd get your MBAs and MBLs, which one can do as accelerated program. I'm talking of a shorter time investment. To get a traditional CEO to that level, one's talking 10 to 15 years. A medical doctor in a similar level, you've got the added benefit of that insight and foresight. And that critical insight and foresight can't be bought, can't be studied. That comes purely down to, because medicine at the end of the day is part science, part and art. It boils down to your experience. In terms of health leadership, Peter Drucker famously said, management is doing things right, leadership is doing the right things. And in my perspective, the ability to fully understand can sometimes only be had once something is directly experienced. You can be told about it, you can hear about it. Think of Magnum ice cream. You can hear everything you want. So you've tasted it, Nothing justifies it. Or for the ladies, lint chocolate. Some of our men wouldn't understand it, I still don't, but there's some experience involved there. In terms of healthcare leadership views, you may have short-term optimization, which is what I regularly see. There's optimization in saying we will save cost. But have they seen the cost of their patient over the next 5 years? You cut short their treatments, you limit their exposure, you limit what they get, but on the long term, you actually lose it. Yet, doctors potentially, and I'm not saying will, potentially have the ability to have that insight to say, we can optimize this. We spend a little more now to optimize long-term outcomes. This was a topic mentioned yesterday about Prof. Actuaries and accountants versus doctors. Yes, they can crunch the numbers. They can give us fantastic perspectives on what the numbers make, what the probabilities are, what statistics look like. They'll tell us about the short-term costs, but they won't tell you about the long-term costs. They'll give you the probability of the long-term costs. They can't predict what he's going to do. Neither can we. When at this point, when you're there, when your family member is there, when any of your dependent is at that point, who do you want to be making those decisions? Someone looking at the entire business model, or someone who's actually been there at some point? That is the reality of what we're dealing with. The car decision again, when we spoke of who do you want to fix your Mercedes? Someone who's fixed a Mercedes before and knows what works in it? Or someone who knows the business of selling parts? Or someone who actually knows what's going on? That's a decision one needs to explore within yourself. Drivers. There has been some recent research that I've obtained from some of my colleagues, in which the management and performance of the hospitals have been quantified in the United States. In the study that I referred to, is there were 235 hospitals that were reviewed. 122 of those were in the top respective categories, from the top 100 in the performance institutions. Because there's a strong calling. I know France has specialized programs in which they do specialized training. The United States has now what they call dual degrees. You can do an MD/MBA by adding on a year. So you come out as a health manager and as a physician or medical doctor at the same time. Because they've seen the insight. They see the necessity of having both the skills. Because something that also came out quite clearly yesterday is doctors learn to be doctors. They've never learned to be practice managers. They've never learned to do management. All they learn to do is manage patients. But given a year or two, given some exposure and experience, they can combine those two and optimally give adequate leadership and insight. Just so we can, I do need to, and some of the topics, and I've dug a little hole for myself on risk management and mitigation, just to step back for a moment from risk mitigation, the human cognitive processes. Decision-making and risks are fundamental. It's part of the normal everyday process. People make decisions that are related to perceived rewards and risks. Now, the key thing is perceived. And perception is directly influenced by experience. Your perception is only limited to your experience. You can only perceive those risks and values if you've actually experienced that to a large extent. And that process is largely dependent on those perceptions. The perception of risk varies from person to person, and in relation to the potential effects of the risk management. That means when one talks of health risk management or patient profiling, one needs to understand that. And it's a very subjective process. Let's be honest with ourselves. There's no objective risk management. Everything is subjective. It's subjective to the point is if the doctor fights hard enough, he'll get to a medical advisor, and if need be, get to his lawyer, and then suddenly the processes change. But does one have to really go through those processes for health management? This ability, as they say, is a basics violence is essential. But one tries to minimize pain and maximize pleasure. That's typical human behavioral thinking. Pattern recognition is where the brain takes in incoming information and stores it temporarily at a superficial level, and then compares that to previously stored information to make the assessment. Now that previously stored information cannot be put into someone who's not medical. He cannot compare, how do we manage this first time? How did that patient pan out, the one I dealt with in 2003? Is it possible this could complicate into something further if we refuse this basic? Yes, the antibiotic's expensive, it's 900 Rand, you'll end up in ICU, it's going to cost you 200,000 Rand. You can only have that baseline if you've actually been through that baseline. Well, now that we're on the topic of ICU. Moving on to the concept of risk. Risk is all around us. It plays a part in virtually everything we do. In South Africa, I think we're not risk averse. Getting out of your house is a risk today. Driving on with South African roads is a risk. But in terms of risk management, and in a corporate structure, one needs to consider both the individual risks and the overall collective effects on the other risks. Because yesterday we spoke of the distributive justice, the value of, can we give value to everyone? Yes, there is risks in trying to quantify and qualify, but an individualized perspective on each case is critical. The net impact of the individual and collective risk can be quite different. The risk is a measure of the probability and consequence of not achieving a specific project goal. It therefore depends both on the likelihood of the event occurring and the consequence, the impact of that event should it occur. Now yes, there is statistics to say if patient X is not treated optimally now, he may actually recover or he may not. But there again, experience plays a very critical role. Not in all environments though. Health, risk and risk management. Risk and risk management should not be seen as purely static, which it has become to a large extent. You have these policies developed by the various managed health institutions. They dogmatically follow these processes because they've been advised to do so. And it's not about identifying purely potential negative events and then taking precautions against it. It's looking at the complex world of business, and in this context, the world of business is healthcare and healthcare provision. And, well, healthcare and analyzing the myriad of opportunities that present themselves. That means being aware of what's going on, being aware of what's happening in the broader context of healthcare globally. Finding out what optimal treatment strategies are being employed by colleagues in other countries, comparing that to what we're doing, and trying to implement that quicker than waiting for the next conference in 18 months to present your glorious paper. Because in 18 months you could have saved a hell of a lot more people besides getting your academic papers. In order to succeed, institutions have to take risks. Now, when I say risk, it's not saying risk-seeking behavior, but take calculated, well-informed risks by people who have the insight into knowing exactly what goes on. Yes, one is to commit scarce and expensive resources to those uncertain activities. I think this uncertainty that one generally speaks in the broad concept of risk can be mitigated to a large extent by relevant experience. That's purely what it boils down to, having had experience to deal with patients on the cold face. And the more research and analysis that can be put into risk, and understanding that it's what underlies making those activities better. It's about optimizing those strategies. But there again, it comes with experience. Risk is therefore a good thing and a bad thing. It's a driving force behind innovation and enterprise. I mean, as our colleague Anton is working on fantastic projects, I think the opportunities are there. There needs to be a willingness to actually get involved and do something. Because one can sit back and, forgive my French, but one can moan about everything that's going wrong and what doesn't work. But if you're not actually going to make a direct input, it's pointless complaining. Because there's already enough complaining around us. But one needs to also look at the threats. That means measure what these threats are if one looks at risk mitigation. Are they actual threats? Is the only threat cost? Or is there a threat of actually losing patients? Is there a threat of actually not optimally treating patients in trying to mitigate that against profitability? Not profitability of the medical aid, profitability of the managed care organization. It's particularly significant in the health context where work is typically complex and does not form a repetitive cycle. We work in environments, and managed healthcare manages a system that's not static. It's not like manufacturing cars. It's not like any other industry. It's a dynamic organization. It's a dynamic system in which one needs insight to be able to optimize that. There needs to be a willingness to manage this on a case-by-case basis with relevant insight. Or if not on a case-by-case basis, relevant leadership and management to enforce and instill this mindset and thinking in various organizations. Just looking at the typical models of risk management, it's about risk identification, classification, analysis, attitude, and response. To identify those risks, one can see the business model. But to identify the risks of patient profiling is a totally, totally different matter. To classify the risks, which we see on beautiful documents and white papers, one can classify risk profiling and classification of cases. But when one then breaks that case down to that individual and what's actually going on, that risk suddenly takes a different picture. Then to provide analysis to what you've identified and classified, you need to have the relevant insight and the attitude to say, this can be optimized or this can't. I'm not saying spend on every procedure people ask for, but having someone who's been there would be able to say this is justified, this is not. But leading with that kind of mentality would change the system to a large extent. Medical experience optimizes that risk review as noted. The attitude of the risk taker is obviously an element of risk management, especially in the healthcare environment. Much risk evaluation is subjective and therefore again as taking on the point of it is perceived. And that's where risk exists to a large extent. It is purely about perception. Different people exhibit different types. And risk response basically centers around that distribution. Everybody works on a bell curve. Everybody works in laws of averages. We've got fantastic actuaries that give us beautiful numbers. But do they actually project what this patient may have? Because when the patient signed up for their medical care, they weren't told we'll analyze your probability. They were told we'll cover what you need. Then when you claim, oh, we'll exclude what you need, we'll give you what you think you need. And that's when things start to change. This is putting it very, very crudely. I immensely, again, respect my colleagues who are non-medical. But generalists with management experience leading healthcare, yes, it can prop the system, it can drive the system. Or do you want someone who's done a management program, got some relevant experience, but had at least 7 years, and that's inclusive of the 6-year degree, one-year internship, or 2-year internship. These days with ComServe, you're looking close on 10 years. Someone who's had compulsory, forced exposure to patients, even if they didn't want to. But they've had that experience of managing patients, managing exposure, managing limited resources, especially in state level. They do know what it takes. Applying that on a macro level shouldn't be too much of a problem with relevant support structures. In terms of obvious risk responses, there are the risk retentions, the reductions, and I'm not going to get into too much detail of these. This is purely for completeness. But in terms of retention, reduction, and transfer, one needs to analyze the system. To a large extent, provide relevant insight and foresight. And again, it boils down to the perspective of experience will make that critical difference. Of course, on some of you pulling, depending on your age. This is, I'm not going to mention the names. I'm going to mention an arbitrary area. Let's presume it's not in Fourways, it's not in Johannesburg, but company X is a healthcare management institution. Who's your front line? As far as I've experienced, and this is talking as documented, unqualified pharmacy assistants. For those of us who don't know what pharmacy assistants are, those are the assistants, bluntly put it, who assist the pharmacists. But they do correspondence programs, be it clicks, be it discount, or be it whatever the institution. They register with an institution, they get their books, they start to read. The experience of patients, so they're not allowed to do a final dispensing. They're not allowed to make a decision on the medication. But what they are allowed to do today is decide whether that orthopedic surgeon needs that antibiotic. They also decide whether that patient needs CPAP or continuous positive airway pressure. They decide whether you can qualify for those. How? They're like call center agents. They've got pre-made templates and they refuse everything. They then decide what happens next. On your next level, well, you do get the qualified pharmacy assistant, but these are colleagues of ours who spent 2 years learning how to confirm with the pharmacist what to issue. But they've never been, and this is putting it as bluntly as it comes, this is what's happening today for an institution that manages more than 20 different medical aids currently. They're case managers to a large extent, or leaders on those teams are pharmacists, who are fantastic experts at drug management, but not patient management. They have a large extent of clinical exposure, but do they have enough to question an orthopedic surgeon's decision, or a neurosurgeon, or a GP with 20 years experience? I'm not sure who gave that authority, but that institution believes they're making a right call. There is the review of the drug utilization. Yes, it does exist. It goes to a case manager who's got 0 million. She then decides, I'm going to advise on this. Then, obviously, the questions come about special investigations, what's authorized, what's not, with those kind of people, special devices, and medical review process. Put it bluntly, this is the process that institution currently follows. You've got first point of contact, your pharmacy assistants. They decide should or shouldn't we authorize this. When you don't fight it, it goes to a team leader who reviews it after. Now, how many doctors have the time to go fight for the patient? If it's refused, they're going to work with what they have. Then when it goes to a team discussion, and I can tell you this factually, because I've had phone calls asking what I think on this website. because I know people who work there directly. They then consult Google, trusted old Google, written by non-medical doctors, written by non-professors, on websites that anybody could have put on. They then decided, they looked at a trial, and the trial said X. Or they looked at a article on someone's commentary, and the commentary says don't use it. They then say, okay, cool, we'll do it. It takes sometimes up to 2 weeks to have the first doctor or nursing review of this case, and there's a final opinion saying the patient is still in ICU, I need this. Not all the patients will last 2 weeks in ICU, I can assure you. Especially if you haven't given them what they need. But this is what's happening. This is the blunt point of what I'm trying to make, saying not the right people are in the right places. Yes, this institution is led by a very senior colleague of ours who's long overdue, as mentioned by Prof. Chidi. He's grey, gone bald already, he's past that point. But he's a doctor, yes. He heads up the institution, but he also heads up 20 such companies. He sits on all these boards. He's not going to give insight. But you need people on the relevant levels of health management and leadership to provide direct insight. Do you blame the pharmacy assistant? Do you blame the pharmacist or the team lead? No, you don't. Because when they were employed, they're given a 2-day induction. This is what you approve and this is what you don't. This is what you do when someone fights with you. And if they fight with you again, you put them on hold for a while. So hoping they're not going to call back. But that is what actually happens. But you need, in these levels, be it from junior management right up to senior leadership, you need relevantly skilled and experienced individuals who know what needs to be done. You shouldn't be sitting at that point deciding, does he need a CPAP, does he not? Because the first thing you tell a patient, or if you would talk to such individuals, the patient needs assistance. They have sleep apnea. What is his saturation? It's irrelevant what his saturation is. We've done the physiology studies. The patient is struggling to sleep. What is their impact? No. He's getting normal oxygen. He's saturating at 99%, which is normal. But when he falls asleep, he starts to sort of semi-suffocate himself as his soft palate keeps falling back, which is a chronic thing. They then want you to justify with various implications. But what happens with sleep apnea? The patient doesn't rest. His body is continually in shock. He starts to fall asleep at 9 o'clock. He takes stress leave. His blood pressure goes up with continual spikes of adrenaline in his body every time he starts to suffocate when he's falling asleep.
Just hang on.
You're then treating the hypertension. You're then treating everything else. But what could you have actually done? Approved what the doctor thought he needed in the first place. And yes, I speak from experience because I've had cases like this, in which a case-relevant individual refuses because the patient's saturation is more than 90. So he does not need assistive devices. On what grounds? That's what we work with on a regular basis. Just to take the topic further on it, in terms of short-term costs and long-term costs, I also do work in anesthesia. One of the biggest fights we have currently with our patients that we outsource, short-term costs of cheaper CVPs. For those who don't know, it's a central line that's inserted into the neck or into the subclavian vein. It's to give us IV access for urgent cases. That's your ICU, your IK, major operations. You get the argument saying, why don't you use the cheaper product? When you try to explain to them that you're going to end up in 10 patients opening 12 packs, because 2 of those will be defective, they can't seem to see your reasoning. But when you claim for 12, they ask, why do you claim for 12 or 10 patients? You then tell them, well, these things actually only lasted 3 days and then they started to clot, because those little lines are very thin. They started to clot. You used the original that we used 10 years ago, or 5 years ago, which cost twice as much as the original pack. It lasts you 3 weeks. You then remove that and replace it as required, or whatever is required in terms of medical protocol for the patient. But you end up in a discussion and an academic fight of saying, my experience tells me that the more expensive one will work first time, but last 3 weeks. The cheaper one may work first time and last 3 days, and then we'll claim for it regularly. You're willing to pay for that every 3 days, but you're not willing to pay for one that lasts 3 weeks. That's the CVP example. Antibiotics is also the same discussion. What treatment do you give when? And who has the discretion to make that? As Prof. Snyman mentioned yesterday, if you have the relevant consultants, the relevant leadership, he himself being a medical doctor and now a professor, but having the insight of what needs to be done gives you a framework. But when you look at the general spectrum of managed healthcare, not all of those protocols are optimized. they're not optimized for patient care. They're optimized for cost point. I have a lot of our patients where if you phone medical aid and say, listen, is this authorized? They would authorize something, just trying to think of a relevant example. There was a case 2 days ago, a natural treatment, discovery authorized for 85 Rand for stomach cramps. It's on code, it's got a nappy code, 85 Rand, works fantastic. They refuse something for that is a proper drug. Scopex? Sorry, general exclusion. Cost 25 Rand. What are your guarantees that the natural product is going to work? I'm not discounting it, but I've got more papers proving Scopex is going to work or Buscopan is going to work than your natural product is going to work. But you'll pay 85 for that, hitting and hoping, and the patient's going to come back and you're going to pay for a second consult. And at the third consult, we're going to then send him to a physician. But they will pay for that, but they won't pay for the cheaper product that actually works. That's been in the industry 20 years. It's a general exclusion. Now these are the things one starts to question, who's making those decisions and on what information? Oncology drugs are just the same. The argument would come about, why do you want an expensive product versus a cheaper product? Well, the expensive product you're going to waste half. You're not going to use all of it. You have to dilute those drugs. And as mentioned to me by some of our pharmacists, sometimes you use 1/3 of those drugs, especially your chemotherapeutic drugs. You're going to use 1/3, discard the rest. Why not use something that's cost effective? Outpatient investment. This again was traversed extensively yesterday. Outpatient investigations and treatment versus hospitalization. Why can't the GP do what he needs to do? Why can he not admit the patient into a day ward, which is cheaper? I've had issues admitting patients to any of the medical hospitals in the Pretoria region. They insist we exclusively work for our physicians. And that's the arrangement they have. That's only purely because that's the group I had a run-in with. But why does one not allow a GP to charge his 190 Rand, 200 Rand consult, or whatever his billing be, first hospitalizing patient with specialist care with a range of investigations, when that could have been optimized very, very quickly. Fraud management, I know I did mention it on the topic list, but our respected colleague, Trevor, did an excellent job on that. Just a few key pointers that I just want to bring on that. Doctors have the ability to spot the false claims. You can have the best software. You can employ the greatest technology. Nothing is going to optimize what actually needed to be done for that patient. No system is going to be able to realize this is genuine, this is not. The only person who's actually going to give you that insight is someone who's done it themselves. Medical fraud can be disastrous to help patient and the reputation, false claims, misleading statements. You do get regularly, whether it's misleading claims, misleading things in terms of negligence or intent. And the biggest fight we have with our colleagues is the intent. People willfully misrepresent, willfully, wrongfully bill. But that can be optimized by someone who has insight into what actually needs to be done. And this phrase, pharmaceutical prostitution, used to be one of Prof. Jacques' favorite ones back when he used to lecture. I'm sure, and I've seen many of our colleagues are medical doctors here, what is the demographic profile of the typical rep that comes to you? I'm not going to get into the detail. But the patient knowledge is this much, and that's slightly longer than the dress they wore. But what are they motivating you to sell? And I'm being honest about it because at one Montefiore hospital, that's typically what you see. The doctors will not hear you if you haven't brought food. If you bring checkers, they don't want to hear you, they want willies. That's the level it's reached. There's no willies food, and there's no incentive in free gifts, they're not going to hear your discussion. That's how they motivate for drug utilization. But these are practical cases. This is what happens every day. And the person who's telling you about the drug probably hasn't studied medical. 80% of those have done sports science, or biokinetics, or something related to medicine, but have never really worked with the product. And you ask them, how does this compare to the other product? They pull out the leaflet, they read that. But if you wanted that, you could have posted that. But that's what you have in pharmaceutical prostitution, because Prof. Snyman's thinking was, people jump product to product depending how exciting you stimulate them to sell the product. And I talk about products. But it boils down to what do you use for what reason? And who's stimulating those decisions and on what incentive models? Medical legal compliance, experience and prior exposure is critical. Capacity to understand the environment and know what's legal or not, and we have our expert colleagues who can give us advice on that. Again, law is not legislation. It's the interpretation and context by the courts. A lot of our colleagues and a lot of institutions skim it and say, this is strictly by the book. Yes, that can be changed. Because in the broader context, our courts are very sympathetic to the demographics of our country, they're sympathetic to the history of our country, they're very sympathetic to what is the net effect of what you've done. I've had a lot of cases where you have the likes in Pretoria, you've got Judge Prella, who, if an applicant brought a matter to the court and said, this is our application, he would ask questions they never anticipated. And then you sit back and go, hold on, where are we going with this? They even tried to take the case out of court. Judge says, hold on, I'll do justice for it. And there are times where he will rule against both parties. So there are the interpretations of courts, and it can go both ways. So litigation is what some people say easy. You've got MPS to cover. Very hard. Because MPS only means they will fight with you to the point of court. When you get to court, that's a very, very different matter. So medico-legal, I think we've covered that to a large extent. Talking of real-time technology earlier, using newer technologies just makes life easier. It's daunting. Yes, it is. Because there's too many devices. You've got an S3 phone, you've got a new laptop, you've got an iPad, you've got Samsung, you've got all these toys, and you don't have the time to get to anything. But fear of those devices or the technologies isn't going to change anything. Making time to understand their usefulness will change it. I'm not advocating using specific devices. I'm advocating don't resist the change. If you do, you're going to be the only one still manually writing things. In terms of investments, should one really invest in training of ambitious doctors? That means within your institution or your organization, you've identified someone saying, I'm good at this, or I want to be good at this, I want to move out of clinical practice, but take that experience into management. Should it be optimized? Most institutions globally are already seeing that. A lot of those colleges, like in the States, offer dual degree programs because opportunity is there. It just starts to make a hell of a lot of sense if you do it early. Because the on-off relationship between management and the medical field is typical. If it be within a micro level within a hospital, or macro level within a medical aid on the hospital claiming for relevant treatment and procedures, that relationship would be much improved if management, which they are doing, has some insights into the medical world. But if you had more medical people in management, lending that insight, sitting on the levels where they need to be to provide the level of advisory. This is just skills versus age. This is just extrapolating the topic as a quick overview. Just some thoughts. Does age imply better skills? This is stepping away from it for a moment. Does it really imply better skills? You look at the Mark Shuttleworths, you look at Zuckerberg, you look at some of the leading industry people in the country. Vinnie Lingham, who's probably sitting in the States with about 200 billion rand. Academia. Is it still the true gateway of knowledge? Does it mean because you've studied through an academic institution or you're at an academic institution, you know more than the man on the street? Using technology today, one can have access, and it's as simple as logging onto Google Alerts and put on the topic you're interested in, you'll get mails every day when the topic pops up. As fast as Google gets it, they'll get it. Is performance capability measured by experience only or by enhanced exposure? This is a topic we traversed with the CSIR quite a while back, and there's big opposition from the universities. Because South African education is still very structured education. If you were to call Prof. Sanjeev Chopra, who is the head of continuing medical education at Harvard, if you were to talk to him, he'll introduce himself as Sanjeev. Yet behind his name, he's got a 5-line paragraph of what professor he is and what's his credentials. Locally, if you address someone outside of it, and I'm not talking to our respected colleagues here, but at some of the institutions, they're very stuck on their titles. They're very stuck on the institutional power that they have ordained them. But does that mean they are the true experts within their field? If you got someone who's in their whatever age group who doesn't have an academic title, who just takes the time to read the relevant literature, not only those that have made a peer-reviewed journal 18 months later after the data was available, but someone who reads it as it comes out in someone's blog about what actually happened. Who's more at the cutting edge of what's actually going on? And who's got a better insight? That's something you're going to have to find answers for. In a quick summary overview, experience in specialized skills in the practical setting does have relevant insight. My take is using that in management and leadership does make a difference. The ability to understand treatment preferences, because you've been there, you've done it, you can have a better strategic input. Risk understanding and mitigation. The risk understanding and mitigation is not just about profitability, but long-term value for the patient as well as the institution if it's optimally managed. Case insight and immediate feedback of actually knowing what happens beyond the case number. Provide leadership with empathy and foresight. And the foresight again is being able to say, we'll invest X amount now to mitigate far larger cost of hospitalization or specialized care at any stage. Some of the references are some of the works from Yale, from INRA, and some of the slides of our colleagues from SlideShare. And if anyone does want to get in touch, these are my contact details. Email makes it pretty much easy. If you've seen the link in the brochure, it's terrence@kommal.com. And if I have offended anyone, I apologize. It is purely to provide an insight. And that's exactly why I want to.
We'll open the talk to a few questions. You guys are all content and convinced. I'm not convinced so much because first I was told that if you grade, you got a problem. Then I was told that if you're younger and you read, you're probably on the same level. So I'm trying to place myself somewhere along the line and I don't seem to fit any category. So I'm going to give it a thought.
If there's no questions, I would like to just make an observation. While you were speaking about all those risk issues, and we spoke a lot yesterday about managed care, I was trying to think of a good example of trying to prove that managing care of the patient is actually better than managing the finances. The funders and the payers all are managing the finances, and the caregivers and the patients all want care. They want the care managed properly. And I actually thought of a very good example that we had in our own company. Years ago, I was consulting to Sun & Son, and my task was to set up a completely new Medicaid scheme. We did it with 3 options. We selected an administrator to run the scheme. They costed the benefits. We managed the benefits and we managed the costing from there on for 7 years. And you know that the whole focus of that scheme, we made sure that we focused on care, on managing the care of the patient and giving the care that was required, because we actually believed if you give the right care at the beginning, you save money down the line. That was the philosophy. We did not focus on managing the money like is done now. To so much money spent on managing the money, I think we've lost the issue of care. Anyway, 7 years later, we had, at that point in time, the best scheme in the country with the best reserves.
I think
so. It worked.
Yes, and you know, adding and extrapolating on what you're saying, that was the pivotal focus. The focus is the patient. Yes, there's profitability. Yes, there's bonuses paid back when you minimize your cost to the medical aid and the administrator. But that isn't the point of what managed healthcare is about. Managed healthcare is about managing the healthcare, not just about. Yes, there's profitability. We know there's money in the business, and as mentioned yesterday, our entrepreneurial colleagues are making a killing when we're starting to unbundle their services. That does not change. What are you in the business of?
So something just noted also, you mentioned that the wrong people, I would say in inverted commas, are in the wrong positions or decision-making positions. Is it something that we are looking at to maybe try and change, or are we then leaving the status quo to say, it's like that, it's this scheme that says they'll put pharmacists there and they'll put these students there, and you sitting there as someone who's frustrated.
The broad guidelines, the broad framework that the industry accepts is a healthcare professional. These organizations say because you're registered to become an assistant, you're almost a professional. So they try and skim, we're talking cost mitigating, we're trying to keep the cheapest level of service for maximum profitability. But if you actually look at the number of people you've put in that upstream, you've got the pharmacy assistant, you've got the pharmacist, the case manager, then the medical case manager, and then the medical advisor. You're now paying 5 people to do that job. And I can assure you, at 5 o'clock, because I know I used to call some of them just before 5. Sorry, sir, people are gone. Medical advisor phone tomorrow. Patients admitted now. Sorry, sir, there's nobody available. And that's the challenge you have. And these are colleagues who've been very entrepreneurial, they've rebranded twice, specific institutions. But it's purely in an effort to say, we want relevantly skilled people. I'm not saying man every post for doctors. That's not what I'm suggesting. I'm suggesting have the relevant insight and leadership to regularly optimize that. So even if you don't have the relevant qualified people at the cold face, they have the insight and understanding that you're just a phone call away. Like you have in state hospitals or wherever you keep, you're a phone call away. Have someone available on call. It's cheaper to have someone on call and paying for the night to be able to answer his phone and say yay or nay, or I'll talk to the doctor directly, than having to hospitalize that patient a week later for 6 weeks.
I'll take one more question.
I think it's more of a comment, but I think some of the points made by the experience of this organization is certainly an organization that, if it exists, is somebody that could not be accredited by the Council for Legal Schemes, because there's certainly a regulatory framework governing managed healthcare. And some of the stuff I've heard here would certainly fall within the ambit of what will be allowed for managed care organizations to do. So I think one probably needs to understand the regulatory framework, and when these actions that happens within the scope of the regulations, one needs to bring them to the attention of the regulators. That's one comment I can make.
I'll make a concluding remark now. So thank Terrence for his input and giving us a share. I do a lot of talks on leadership. I just want to say my take-home message is very simple. I think healthcare leadership needs a lot of humility. That's the first thing. Healthcare is dynamic. You learn every day as you go on. I think the only way you can do and be a good healthcare leader is to have expert committees. You need a lot of collaboration and interdependence. So I think it's just what we heard today. We've got to work as a team, and the team has to work, because you can't manage healthcare in silos. So I think that's the take-home message.